Hi, everyone. Welcome to Hand Surgery Essentials from AO North America. Tonight is our first installment of a series of lectures for Hand Surgery Essentials, and I'll be discussing surface anatomy of the hand and wrist, including hand and wrist exam. Also, Dr. Kimberly Mesra and Dr. Amit Gupta will be joining us for the lecture. All of your microphones have been muted and your videos have been turned off. We welcome all questions throughout the entire lecture, but please use the Q&A part for questions related to the discussion topic, but do not use the chat box. Our learning objectives for the night are to be able to identify skin creases of the hands and wrists, muscle prominences, bony prominences, tendon elevations, and the nail anatomy, and then be able to use these in order to diagnose underlying pathology based on the surface anatomy. I'll also be adding in clinical correlations for these in order to help give examples. So I'm starting off with the nail anatomy, as it's one of the most obvious portions of the hand, as you see. It's on the right-hand side, there's a picture of a patient's nail. You can see what's commonly known as the nail is also known as the nail plate. Underneath is the nail bed, also known as your sterile matrix. Proximal to that area is the germinal matrix. The nail the skin surrounding the nail is known as the paronychia, proximally the echinocchia, also known as the cuticle, and then the hyponychia, which is where the skin meets the distal aspect of the nail. What's interesting to note, as you see here on the left-hand side of the screen, there's a drawing. The distal phalanx is very close to your nail bed. So if you have a nail bed injury, it's important to think about a fracture of the distal phalanx, as it's quite close. In addition, your extensor tendon is quite close to your germinal matrix, and your flexor tendon is just on the volar side. So while just thinking about the nail, it's important to think about the underlying structures and what's going on with them as well. On this slide, we see here on the right-hand side, there's clearly a nail bed injury. You see the blood coming out of the nail folds. There's a subungual hematoma. But what you need to think about, as stated before, is there an underlying fracture? Are the tendons intact, and so forth? On the left side of the screen, on the top part, we see here a schematic of a drainage of a paronychia. Hands, unfortunately, get a lot of infections, so it's important to understand where these infections are and where they come from. As you see here on this last picture, in the drainage of a paronychia, there's a pocket of pus. This happens a lot, and it's very important to drain this area, because if you're unable to, or if you do not drain it, your infection will continue. On the bottom portion, we see here a schematic on how to drain a phelon. The incision is a mid-lateral incision. It's dorsal to your neurovascular bundle after it has already branched. But what's important to note is volar is where your pus is. So you go volar to your distal phalanx and you break up your septae in order to drain your pus in the area. And you'll learn more about these next week in hand infections.
And I think too, one caveat or one little bit of advice to the participants is the incision, like as shown in B and C there, be cautious about that incision in the eponychial fold. That can leave a little unpleasant, cosmetically unpleasant scar. It puckers that fold, and it can be very difficult to fix that. And it's noticeable, especially in women. And it's just mostly a cosmetic issue. However, just be careful about that. And I prefer to actually avoid that type of incision, and rather I would like to use, as shown kind of at the bottom there, the mid-lateral type of incision, where you can actually easily and safely reach your eponychial space, your eponychial fold area, to decompress that, but also through the same incision, you can reach your septa and the loculated pus in the pulp of the finger too, as Dr. Grossman was referring to. So just a little tip, to consider. And the same, you could use the same logic, I think, and just be careful when you're doing distal mucus cysts too, because the eponychial fold gets disturbed. It can be really difficult to cosmetically fix that.
As we move on to the rest, to the hand, we move to the dorsal surface of the hands. On the left side, you see a hand with the fingers in extension. In doing so, you're able to see the extensor tendons as they're underneath the skin. In most patients, you are able to see the extensor tendons through the skin. As you can see here, we have your EPL tendon, which is one of the borders of your anatomic snuff box. Here we see your first dorsal interosseous, your adductors, and your musculature, which is important to note. And then the EDC as it goes to each finger. As you move distally over your MP joints, you're able to see the extensor tendons, but there's also on the radial and lateral borders, there are structures here, and it's easier to see in this drawing are your sagittal bands. These sagittal bands help hold the extensor tendons in place. If you end up injuring one of the sagittal bands, your tendon will sublux and move out of place and dislocate. We can see here on this video just that. You see that extensor tendon subluxing to the ulnar gutter. Sometimes this can be mistaken for a trigger finger. Patients say, my finger gets stuck in flexion and I can't extend it, as the extensor tendon gets caught in the ulnar gutter and you can't actively bring it up on your own without using your other hand to flex it, extend it, excuse me. It's very important to examine the entire hand when you're dealing with this, because what you might think of one type of pathology actually can be mistaken as another pathology. Other important things to note on the dorsum of the hand, as we were talking about extensor tendons, are extensor tendon injuries. And we see here on the drawing is a drawing of Verdun zones. What's important about these is to know the zone of injury. The purpose of knowing the zone of injury is to determine how you treat the patient. How are you going to fix this surgically or not surgically? How are you going to splint the patient? Are you going to splint the patient? What is your rehab for the patient, and so forth? A little tip is to understand or to remember that the even zones are over your shaft of your bones, and the odds are directly over your joints. Later on, Doyle made a revision of Verdun zones and split zone 8 into 2 zones, making it zone 8 and 9. Again, for the same purpose, to understand how to treat these as they are treated differently in these zones. Next, we move to the volar aspect, or the palmar surface of the hands. We all have looked at our hands multiple times before. You see the creases in your hands. You know your DIP, your PIP, your MP joint creases, which are quite evident. And then you have your distal palmar crease, your transverse palmar crease, your interthenar crease, and so forth. You can also see your hypothenar eminence, your thenar eminences, the muscle bulging, and all of these are helpful to understand what is underneath. In addition, they're very helpful to figure out what your surgical lines are and for surgical planning. Here's a drawing of the same thing with different lines. We've all heard, or maybe haven't heard, of Kaplan's cardinal line. And this is a line drawn from your first web space parallel to your proximal transverse palmar crease. If you take a line from the ulnar border of the ring finger and draw it proximally, and then you draw that to Kaplan's cardinal line, you end up hitting your hook of the hamate. What's important about your hook of the hamate is it lies just next to Guillen's canal in this area. So these are all helpful landmarks to understand other things. If you then take Kaplan's cardinal line and you draw a line from the radial border of the long finger, you then hit your recurrent branch of your median nerve. From all of these lines plus other lines, you're able to identify just superficially where your superficial palmar arch is, where your deep palmar arch is. You can use these for incisions, for a carpal tunnel release, and so forth. So all of these lines are very important to know in your mind's eye when you're looking at a hand to understand what injuries may occurring, what incisions you might make, and so forth. As we had Verdun zone on the dorsal aspect of the hand for the extensor tendons, we also have them for the flexor tendons. Again, the importance of these zones are to understand how to treat a patient who has a flexor tendon injury. Again, how you treat them, how you operate on them, what type of repair you do, what your rehab is, what their expected outcome and function is afterwards, what else may be there besides a flexor tendon that may be injured as well. Other things that we think about when we look at the volar aspect or we look at the hands are infections. Unfortunately, the hand has many infections, which you'll be hearing about next week. What's important to note is that all of your flexor tendons have a flexor tendon sheath. These sheaths all can get infected. The first and the fifth commonly are connected, and you can end up with what's called a horseshoe abscess. When you have a patient who's complaining of pain, inflammation all along the area of the palm that goes all the way from the small finger to the thumb, but the other fingers are not included, you may want to start thinking about infections. There's also your mid-palmar space, as you see along here, which is dorsal to your flexor tendons, but volar to your musculature. Your thenar space is just deep to your thenar musculature as well. There's also peroneal space, which is your distal palmar space of the forearm, which here you could see is dorsal to your flexor tendons and volar to your pronator. This is a drawing of how to release a compartment syndrome. And we use these drawings that you see on the top are based upon the anatomic structures underneath, but we use our skin creases in order to determine where our incisions are. So as you can see here on the left-hand side, this is a patient who has compartment syndrome of the hands. In order to release it and to release the multiple compartments of the hands, as there are so many, you must make multiple incisions. You make it on the dorsal aspect of the hand between your second and third metacarpals and between your fourth and fifth metacarpals. You're able to reach between your third and fourth metacarpals from either incision. Also, you might be able to reach the dorsal incision over your adductors from your incision between your second and third, or you could make another incision. Volarly, you make an incision over your hyperthenar eminence in order to release your hypothenars. You make a radial incision over your thenar eminence in order to release your thenar eminence and that compartment. And then there's a carpal tunnel release, which is using the interthenar line as well. And so all of these skin markings are quite helpful in order to determine where your skin incisions are, what's appropriate, and to understand what's underneath. Next, we move to just a physical examination of the hands. What I find to be very important of this is to understand where your fingers go and what rotation of the hand is. It's quite important of the fingers. We deal this a lot with dealing with fractures, whether it's a metacarpal fracture, proximal phalanx fracture, middle phalanx fracture, and so forth. As we see here on the left-hand side, you see all the fingers point down to the scaphoid. When you have an injury, this may not occur, and you may have scissoring of your fingers. So it's quite important to understand that. If you have a patient who has all of their fingers just an extension with an injury, your hands may look completely normal, but when you have them flex it, or you do tenodesis, or intraoperatively do tenodesis, you're able to determine whether or not your fingers are rotating and scissoring. As you can see here on the top, there are examples of both a metacarpal fracture and a proximal phalanx fracture. It isn't always quite so obvious, as I've seen many fractures that look completely non-displaced on an x-ray, but upon performing this exam in the office, the patient has malrotation. So you can be fooled by your x-rays, and it's quite important every time you're examining a patient with any of these injuries to determine whether or not there's malrotation of the finger. On this bottom picture here, this was actually a picture of a malunion, and you could see here this patient had scissoring, and the patient healed that way, so was going to undergo an osteotomy in order to correct for the malrotation. When looking at the hand, you also are just looking directly at the hand, your musculature, as we talked about prior. On this picture right here, you could see it looks as though there's a hole in the hand, right at the thenar eminence. This usually indicates there's a median nerve injury that has been long-standing. There is APB wasting. This could be a patient who has severe carpal tunnel who's waited a long time. Before you even start examining the patient, you can just look at this patient's hands and already know what the patient's diagnosis is going to be. We also see the same thing when we look at the hand for the ulnar nerve. On the top picture, you could see a resting position of the hands. You could see there's intrinsic atrophy. There's clawing of the hands. When you ask a patient to pinch a piece of paper just using a lateral pinch, they use their median nerve, which is using the flexion of the thumb, which is called the Froment sign, because they're unable to hold it the other way. When you have a patient have their hands directly just on a table, and their small finger may just stay abducted. You ask them to adduct the finger, and they're unable to do so because of the atrophy and because of the imbalance of your tendons, of your tendons, of your musculature. In addition, you see hypothenar atrophy. So when you look at the hand, you saw just as the previous slide showed thenar atrophy, you could see it on the hypothenar aspect of the hand, showing hypothenar atrophy. You're also looking at the hand, it may look as though it's a flattened hand, a flattened arch, or what we might call a square hand. The intercarpal arch or the carpal arch all occurs from the musculature of the hands. You lose that when you lose your ulnar nerve function, and the hand looks as though it's a square or flat. You can also look at a hand and tell if there's a radial nerve palsy or radial nerve injury. As you see here on the right, this is a resting posture of the hand. Patient holds the hand flexed, it looks as though it's limp. The patient's unable to extend the wrist actively or the fingers actively. Then we move proximally to the dorsal surface of the wrist. On the left-hand side, you see a schematic of a 3D CT, and on the right side, the correlation of just looking at the surface anatomy of the hands. Number one is Lister's tubercle, and it's palpable on your wrist, and you can try doing that now. As you walk your finger slightly distally, you'll feel the finger just drop down into a soft spot, which is your scapholunate interval. Radially is your radial styloid, and as you go ulnarly, you can feel your ulnar head, your ulnar styloid. If you move a little bit more distally, you can palpate the base of the fifth metacarpal. You can palpate your hamate as well, where tend to be other injuries and so forth. Number one was Lister's tubercle, and you can palpate again, try palpating that right now on your hand. What's important about Lister's tubercle is that your EPL hinges off of Lister's tubercle. So when you're examining a patient who's complaining of pain, swelling in the wrist, it's right near Lister's tubercle after you palpate it, you're concerned about your EPL. Is there a partial EPL tear? Is there an EPL rupture? Is there a tendinitis? And so forth. So on the left-hand side, we have a cadaver here that has been dissected. The Lister's tubercle is circled in the blue circle, and the tendon right here is the EPL. It hinges right across there. A way to examine if the EPL is intact and functional is to have a patient put their hand flat on the surface of your examining table. You then have them lift their thumb up from resting down. If you're able to lift your thumb up off the table, you know your EPL is intact, and you can try that right now. A lot of people might say that the EPL is out or is intact when in fact it is not, is by saying that they can extend your thumb from flexing at your IP joint, but that is an inadequate exam for the EPL. As we move distally, you move down to your scapholunate interval. On the left-hand side, we can see a drawing. The scapholunate is a complex ligament with dorsal, volar, and interosseous parts. On the right-hand side, this is a cadaver that's been dissected, and here we have our SL, and here is actually your radius, where it sits in. If you do have a scapholunate injury, the question is it sufficient or not? Is it intact? Is it stable? If it's unstable, then it means surgical intervention. If it is stable, then you may be able to treat that conservatively. In order to test that, there's something called the scaphoid shift test, or otherwise known as Watson's test. You have your wrist in ulnar deviation, or you hold the patient's wrist in ulnar deviation and extension, and then you move it radially into slight flexion, keeping pressure directly on the scaphoid volarly, and you're putting dorsally directed pressure. As you're moving the wrist, you're driving that proximal scaphoid out of the fossa, and as you're moving it and releasing your thumb, you will feel there is a reduction or a clunk, and that shows that that's unstable. And here we could see this in this video right here. The examiner is holding the hands, putting the thumb on the scaphoid. Then holding the wrist in ulnar deviation and extension, and then moving it to flexion and radial deviation. As we move more ulnarly, there's the DRUJ, which can have a whole host of issues, such as arthritis. There could be a fracture. There could be a DRUJ dislocation. On this x-ray here, we see a malunion of a distal radius with a wide DRUJ. We also determine whether or not the DRUJ is stable by examining the patient, and that is called the DRUJ Ballotman test. The piano key sign, as we see here on the left, is that the ulna is unstable, that it's sitting dorsally, and the carpus is volar. And the picture just next to it, this one, this is showing the reduction of the DRUJ. You're pushing the ulna volarly and the carpus dorsally, holding this reduced. On this picture all the way to the right, you could see dorsal subluxation of the distal ulna. You could see that when you just look at a patient's hands. It tends to be quite obvious and happens in rheumatoids a lot of the time, but we don't see it as commonly because of DMARDs. But when you see this dorsal subluxation of the ulna, which will take a lot of your attention, you must make sure to examine the patient's hands, because a lot of times you'll notice that the fingers are held in a flexed position, or at least the ulnar fingers are flexed. And this happens after chronic injury or a long time, as the dorsal ulna or the ulna is subluxed dorsally. And when it stays subluxed dorsally, your extensor tendons are moving back and forth over the ulna, and eventually they fray and rupture, and they rupture from ulnar to radial. Here's a good example of the DRUJ allotment test. And you can see here the shucking of the DRUJ, how unstable it is.
Got it.
As we move ulnarly, there are multiple or a host of problems that can occur on the ulnar side of the wrist, as is commonly called the black box of ulnar-sided wrist pain. There are so many structures in such a small area that sometimes it's very difficult to diagnose these problems. There are TFCC injuries, ECU tendonitis, ulnar impaction from an ulnar positive wrist, ulnar styloid fracture, to name a few. One common thing is ECU tendonitis, and a lot of people are unsure exactly how to examine for that. You feel pain at the base of the fifth metacarpal. There's pain as it goes up the arm. The question is it a TFCC injury or something else? And you can use a synergy test in order to examine ECU tendonitis, and this helps in the diagnosis. So you put the arm in pronation, you hold the radial fingers, and you hold it in radial deviation, and there he's pointing out the ECU tendon. You have the patient then open up those fingers against you, and the patient ends up complaining of pain in that area, and that's diagnostic. Moving on to the radial side of the wrist, there are again a lot of structures in one really small area, which sometimes becomes difficult to diagnose. It's important to note the difference of where the structures are. Number 6 is the base of the thumb metacarpal, 5 is the trapezium, 4 is the scaphoid, 3 is a radial styloid. Commonly, radial styloid fractures and scaphoid fractures are thought to be one and the same, or it's hard to diagnose the difference between. But it's also important to note that if a patient's complaining of pain in the area of 5-6, that you start thinking about basal joint arthritis, where if they're complaining of pain in the snuff box, you're going to think of a scaphoid fracture. And just, a centimeter really changes how you can diagnose a patient. If you have a scenario of a young male who's fallen an outstretched hand and has radial swelling, the first thing that you might think of is a scaphoid fracture, as there's very high sensitivity for that in that area, as recent studies have shown. Other things on the radial side of the wrist are tendonitis. There's decurvatus tenosynovitis, which is in the first dorsal extensor compartment, as shown here. There's you can use this you can diagnose this physical exam. What most people commonly think of as the Finkelstein test happens to actually be the Eichhoff test. There's intersection syndrome, which is more dorsal or ulnar and more proximal, and it's diagnosed with flexion and extension with crepitus and pain in the area. You could see the difference between the first extensor compartment and the second extensor compartment. The yellow arrow is where the first dorsal extensor compartment is, where decurvatus tenosynovitis is. But the blue is where you might find intersection syndrome. So while they are close together, they are two separate entities. Other possibilities of radial-sided wrist pain are scaphoid fracture, as we already went over, radial styloid fracture, there's STT arthritis, and so forth, Bennett's fracture. As we move to the volar surface of the wrist, you can palpate this on yourself. We have our pisiform, which is number 9. The FCU attaches over there. The hook of the hamate, which is number 10, as we discussed prior. 8 is the volar aspect of your trapezium, where you might have patients complain of pain near that area, which is where you're considering basal joint arthritis. And just slightly proximal is your scaphoid tubercle. Of note, a little more proximal to that, and you can kind of see the tendon markings, are your FCU and your palmaris. A lot of patients complain of FCR tendonitis, and it's a lot more common than you might think it is. It's volar-sided wrist pain and occurs from repeated gripping. As the FCR goes through the tunnel, it can become more narrow, more painful. It goes through a sheath, then it goes through a fibroosseous tunnel, and then it finally goes through a bony tunnel and attaches at your base of your metacarpal. Also, you can have a hook of the hamate fracture, and on a regular radiograph, you might not see it, but if you get a carpal tunnel view, you then are able to see your hook of the hamate fracture. This happens from a fall on an outstretched hand. This can happen from batting. A lot of times it happens with baseball players. People might complain of numbness and tingling in your small finger and ring finger, as it's right by Guillen's canal and the ulnar nerve. If this is left for a long period of time, you also can have rupture of your flexor tendon to your small finger as it hinges and rests right in that area. There's also your pisotriquetral joint, where you can have a fall, you can have a pisiform fracture, as we see here on the left. You can see two half moon shapes or half of a circle. This whole thing is the pisiform. On the right-hand side, you could see pisotriquetral arthritis. And right here, you could see there are osteophytes between the joints, narrowing of the joints as well. And this is another reason to have pain on that side of the wrist. So all in all, I believe that we've covered all the surface anatomy of the wrist and hands, able to determine the landmarks, and then use these landmarks in order to help diagnose, and then use the physical exam findings to confirm what your suspected diagnosis is. Thank you. Does anybody have any questions?
So that was great, Lauren. Thank you. I think a couple comments that might be helpful for the participants to think about, and that kind of to reinforce some of the points that you made. One is that when you talked about the cascade, and when you're testing the cascade, I think it's important to always remember to test the cascade in both flexion and extension, because you can see the scissoring and the loss of cascade in one motion in one direction that you might not see. It might look great in extension, but when you actually use your wrist tenodesis and you passively kind of look at the hand and look at the finger cascade, it will be, perhaps you'll be off in your flexion in your fist. So always check both. I think another point you made well that I would like to reinforce is when you were talking about the radial side of the wrist. There are a lot of things there that are kind of really close together. And I think it's a very important distinction to understand how to palpate the CMC joint, the STT joint. The scaphoid as well, but that may be a little easier because the snuff box is a very good landmark. However, I find many patients that I have seen that have been misdiagnosed with CMC arthritis, and when they actually have STT arthritis. And it's literally, like you said, a centimeter. I think it's like a finger breadth or half a finger breadth that you're going to move your finger during your exam at the distal aspect of that snuff box to make that distinction. But I think it's important to know that and just to use that as a tip.
Yeah, that was very nice, Lauren. Excellent talk. What I wanted to make sure is, it's always nice to compare two hands, okay, and to see if they have pain on the other side or how the exam compares to both hands. And the other thing is what I do, supposing the patient comes with a radial-sided pain, which I think it is a carpal metacarpal arthritis. After examining all that, I would quickly examine for other things, like you would examine for common things like trigger finger, carpal tunnel. So examine the whole hand, whole upper extremity, actually. So make sure that you get a comprehensive diagnosis on the patient.
That's a good point. Becky, are you there?
I sure am.
Hey there. Question for you from the therapy standpoint. We talked a lot, especially about like the zones, the Verdun zones. How do you, in the therapy world, can you comment about how you might use those landmarks and how they help you or how they kind of guide you to different things or any other aspect of that surface anatomy?
You know, it's interesting. I wouldn't say that in my practice, Verdun zones have been something that have been informative to me, but I will say that surface anatomy and palpation is incredibly important. And a lot of the tests that Dr. Grossman went over are also things that you can count on your therapist to be able to assist with. So if they're doing kind of going into your rooms to test patients before you've gotten there, they can also help with some of those things. Certainly for us, I would say, especially for joint manipulation and our ability to work with patients with things like intersection syndrome and your Decker veins or your first dorsal compartment tenosynovitis, you want to count on your therapist too to be prepared to do those evaluations and really partner with you in those areas.
Yeah, no, I think so too. I mean, I think we take it for granted a little bit, this surface anatomy, but it's, I mean, the older I get and the longer I'm in that, the more I appreciate how those surface markings can help you look, it kind of make you look good when you actually get the diagnosis right. So it's very important, right? I think we've all been there.
And observation, I think observation, especially of muscle atrophy. I think speaking to the different nerve compressions or the nerve situations, I think are important for therapists to be able to take a visual of, especially the first kind of dorsal interosseous and the web space and the thenar eminence and the hypothenar eminence as a real indication for when, if we get a referral that hasn't come from a hand surgeon, to have those people go to a hand surgeon. So I think the therapist does you a lot of value when they're also being able to pick up on those things quickly, especially when a surgeon needs to be consulted for more advanced types of nerve compression.
Right. Yeah, good point. I think that's exactly right.
Well, one of the things is that, you know, as I see more and more patients in the office, I've come to realize that a lot of people complain of hand pain. And one of the great masqueraders of hand surgery is trigger fingers or flexor synovitis of the middle and ring finger. Always be on the lookout for these two. And they can cause a lot of trouble. It's a very simple diagnosis. And you can just put in some local anesthetic and cortisone, and the patient will say, oh, that's gotten a lot better. So local anesthetic injections when you have conflict in diagnosis, especially on the wrist, that helps a lot in the diagnosis. And then handheld ultrasound in the office is a great help in the modern day.
Yeah, I mean, I think that's true. I mean, I can't tell you how many times I have seen a patient, second opinion, third opinion, and I'm sure we all probably have, that come in with just like that trigger finger is a perfect example. They come in with 2 MRIs and maybe one was with contrast, and they've had an ultrasound and so many x-rays, and it's unbelievable. And when you tell them, you know, just a little tendonitis here, if we just inject it, you'll be, I mean, they kind of look at you like, are you serious? But that's because, you know, again, you know, the physical exam is key, and it really helps to understand kind of where things are at. So that's great. Dr. Gupta, you have maybe a little, presentation to share with us?
Lauren, if you stop sharing your screen, I'll go ahead and share mine. So, yeah, thank you. And share screen, and we'll go into this one. Okay, slideshow, play from the start. Okay, I just want to give a little bit on the Kaplan's cardinal line. You heard that mentioned. What is it, and how good is it? That's the question or the subject of my talk. So this is, you already saw this disclosure information about the different speakers and their conflicts of interest. All the conflicts have been resolved and none are related to this talk. Now you saw this diagram. This is the standard surface markings that are available. The Kaplan's cardinal line is the line from the abducted thumb all the way to the ulnar side, parallel to the proximal palmar crease. And then if you have a line drawn from the ulnar border of the ring finger to this line, you see the hook of Hamate at the intersection, and you have a line drawn from the radial border to this cardinal line. Then you have the motor branch of the median nerve, and then the deep palmar arch lies proximal to it, and the superficial palmar arch lies distal to it, and then you have the 2 digital nerves, border digital nerves, one on the other side, and you have the pisiform in the ulnar side of the wrist. So that's the standard description defined by Emanuel Kaplan. He was a great surgeon and anatomist from New York, and he wrote a beautiful anatomy book which is available even today. So you see, this is another drawing of the same things, but with the wrist bones added, and you can see the relationship between the pisiform and the hook of Hamate, etc. So Kaplan's Cardinals line, there's a beautiful article from Dr. Stern, who did a anatomical study on this, and his team did an anatomical study in Cincinnati, and I'll just describe that. So what is this Kaplan's Cardinals line? So there are 4 or 5 descriptions of it. A is the original Kaplan's description in 1953, and then B is what Kaplan described later on in another paper. C is Dr. Hurst's description, and D is Brown and Gelberman's description. And I'll go through this. So line A was Kaplan's 1953 original description of the line from the apex of the interdigital fold between the thumb and the index finger towards the ulnar side of the hand, parallel to the middle crease of to the proximal palmar crease of the hand. Okay, that's what we looked at the previous pictures. Line B was Kaplan's 1968 description from the apex of the interdigital fold between the thumb and index finger to a 0.2 cm distal to the pisiform. And line C was Dr. Hurst's description of a line from the apex of the interdigital fold between the thumb and index finger to the hook of the hamate, because the hook of the hamate is easily palpated in the hand. And line D was Brown and Gelberman's description of a line extended anally along the distal aspect of the abductor thumb, just a line. So this is Kaplan's original line, the Kaplan's Cardinal line, 1953 paper. So how good are these descriptions? What Dr. Stern and his team did, they surveyed ASSH members, and they found that their survey did not show any consensus. 50% of the surgeons surveyed used the Kaplan's Cardinal line as a surgical landmark, and they used different lines. They use Dr. Hurst's line more commonly, but overall people used all sorts of things. They not only did they use the 4 lines that we described, but they just made up their own line. So it was all over the place really in the survey. So what the team did was they did anatomical study in 30 cadavers, and they did this, they marked the Kaplan's Cardinal line on the x-rays, and then they dissected these cadaver specimens and marked where the, put the markers, radio opaque markers, where these different anatomical structures are. So the median nerve, the superficial palmar arch, the deep palmar arch, the border of the transoscapal ligament, hook of the hamate, etc. They put these markers, and they measured to see how far they were out from each of these different descriptions of the Kaplan's line. And what they found was that these are the lines A, B, C, D as described. This is motor branch of median nerve. This is transoscapal ligament, superficial palmar arch, hook of the hamate. So they found that they were all over the place. They were 30 millimeters out, you know, like way out, 30 points out, 23 points out, one way or the other. So they were not a consistent area where they could pick out on the Kaplan's line, and none of the lines actually fitted with the anatomical structures. So their conclusion was ambiguity exists regarding the definition of the Kaplan's Cardinal line among hand surgeons and in the literature. And although no single line is ideal for locating all deep structure, line C seems to be the safest line to identify hand anatomy. That is the line from the abducted thumb to the hook of hamate. That was Hurst's line. And Kaplan's Cardinal line does not locate deep structures of the hand accurately, but it may assist in making palmar incisions. So it's just a suggestion. It's not a definitive anatomical thing. And although it's been talked about a lot, it's certainly not a big anatomical landmark from this paper, certainly. So this is what we saw before. This is Kaplan's original line, and this was with the radiograph superimposed with the bones of the wrist. So that's all I had. Thank you very much. I'll stop sharing now. and you guys can come back up again. Okay.
So it's interesting, Amit, that there's so much variation there. There's so much, not a, I guess, lack of an agreement. Is that just because there's a lot of different variation in the anatomy of people's palms, or what do you think it is?
I don't think so. I think, of course, there are variations. You know, there's anatomies like that. You know, Dr. Ackland, my teacher, used to say that the anatomical structures are under no moral obligation to be where you think they should be. They are where they are. Okay, so beware of variations. Always look out for variations. There will be variations, but it's not that. It's that the surface markings are very difficult to pick out any particular surface marking on the hand, which has got a lot of flexibility in different postures, etc., etc. Plus, when you do dissections, you invariably disturb these anatomical structures, and you may be off by a few points, a few millimeters here and there, and so that takes into account. I think you should repeat the study in the live patient with ultrasound, etc.
Yeah, no, that's great. We do have a question, and thank you, Dr. Gupta. We do have a question, Dr. Grossman, from the audience, from the participants, saying, would you be able to explain in more detail the difference between the Finkelstein's test and the Eickhoff test, and how those are performed?
Okay, I'm going to share my screen again here. So if you look here on the screen, here are some examples of the Finkelstein, the Eickhoff, and then there's the Brunelli, which is a different test as well, all to test for de Quervain's tenosynovitis. So the Eickhoff test is what everybody considers to be the Finkelstein test, or it's a common misconception. So with the Eickhoff test, you have the patient hold their thumb in their fist, and then you take their hands and you ulnarly deviate to put tension on the radial aspect of the wrist. And what this does is it pulls your EPB and your APL through the sheath, which is already stenotic, causing friction in the area, causing the patient to have pain there. If you look here on the top right-hand side of the Finkelstein, is basically instead of having the patient hold their thumb in their hands in a fist, you're basically taking their thumb, holding their thumb, and doing the same maneuver. It's just not adding the added tension on the area. So the Eickhoff would, if a patient has acute tenosynovitis, which is a chronic tenosynovitis, that would probably cause the patient the most amount of pain, whereas Finkelstein would be maybe a little bit less painful for the patient. And then you have the Brunelli test, which is basically the radial abduction of the thumb, which is also testing and putting stress on those tendons. And that's another way to test the patient in case, whatever reason, the other tests have not been very effective for you. Sometimes this can elicit a response from the patient.
I'll add a new twist to this. I find the Eickhoff test and even the Finkelstein's test very brutal and very painful. I mean, patients will jump out of the table if you do that very quickly to them without warning them. So I think a gentler test, and I've been doing this, and I haven't written this up, so I'll tell you about this test. Now you can differentiate whether the tendonitis is in the APL or EPB, and sometimes there are separate compartments for each of these. So what you do is you first have the patient hold the wrist in a neutral position, then you press on the metacarpal, thumb metacarpal. So you're basically putting tension on the APL. And if the patient has pain at that point, then you will see that then next you put tension on the proximal phalanx. So now you're tensing the EPB, okay? And then you ask the patient to ulnarly deviate. So that's the third maneuver. So maybe, Becky and I could work together and someday write this test up.
So
Dr.
basically,
Grossman, I have a question for you, because I think therapists may do this wrong pretty often, where they ask the patient to actively create ulnar deviation
Right.
as opposed to passively. And could you talk a little bit about the difference between that active kind of you're really ulnarly deviating, putting that passive tension over the extensors versus creating that motion for the patient passively. Is the provocation different, or I just see that's an error that we make?
It's just less painful, much gentler doing it actively because the patient's aware of it. And if you push on this passively and you do that, as I mentioned, patient jumps out of the table. So it's more gentler, I think, to do it actively.
And do you think that most of us would probably provoke if we did it passively hard enough because it's just an uncomfortable position as it stands?
You might, yeah. If you do it hard enough, you might.
I mean, I think I always, when I try to do this, I agree with Dr. Gupta. I think the ICOF test, I mean, if you did it exactly that way, they do come out of their seat and they do get a little upset. But I always do it bilaterally with them so they can compare. So I do it at the same time. And I do warn them that indeed it might be a little uncomfortable. It kind of stretches a little bit just naturally, even without having a problem. But I tend to not really forcefully ulnar deviate them because I do think, you know, I probably already by that time have a suspicion that they indeed have adductor veins. And so I kind of am a little bit gentle with that ulnar deviation and maybe just barely start to do it, kind of like, I guess, Dr. Gupta, you were saying, you kind of stage it basically and see where you're like, okay, I guess we got it. That's enough. We don't need to push it farther. But I think doing it bilaterally is very helpful.
Oh, it's very helpful. And you can start off with the normal side so the patient knows exactly what to expect and what movement is coming.
Exactly. That's a good point. So maybe we do, Lauren, if you could, it might be interesting to kind of go back to your palmar. I think you had a nice slide that has the clinical photo of the palm, and we have just a few minutes to talk about some surgical incisions and just how that we can use our landmarks to.
This one?
No, go back.
This one?
Back one more. That.
I thought you had one.
Yeah.
Maybe that one. That clinical, yeah. So it might be in, yeah, that one. I mean, just so we can kind of look at the palm like that, it might be interesting to just discuss briefly how we can use these lines and where's our common surgical incisions, perhaps a carpal tunnel incision, trigger finger incision, how we would use those lines to guide us to making those incisions.
Okay. So if you do open carpal tunnel, I stay on the radial border of the fourth finger, which is radial border of the ring finger. So you draw your Kaplan's line. I take that as a distal part of the TCL or flexor retinaculum. And if you go on the radial border of the fourth and you draw your line all the way to the distal to the wrist crease, that is my line of incision. Okay. Now, if you stay in that line, you will be ulnar to the nerve. Okay. You'll be ulnar to the nerve, but you got to be. Then you'll also see a fat pad, which is the hypothenar fat pad. And so you should keep away from the hypothenar fat pad because all the hypothenar structures are in there. And then when I do is I open this up and then I would open up the flexor retinaculum and then slide my scissors into the distal forearm fascia. So the distal forearm fascia is thin and you can slide your scissors in it. But be very careful. Don't go towards the ulnar side because sometimes in the elderly, the ulnar artery can be tortuous. So go more towards the radial side when you do that.
That's a good point. I think you have to also be aware on that radial side, you know, you may have your palmocutaneous branch.
But
yeah,
by that time you're deeper. You've looked at your transcarpal ligament, you're deeper plane.
That's right. What about a trigger finger incision? We can talk about how we use our palmar creases to guide us to trigger finger incisions.
Right. Trigger finger, the key is that, you know, you have to know the surface marking of the pulleys. Now, as you know, there's not a distinction between where A1 finishes and where A2 begins. So the surface marking of A1 is from the distal palmar crease or an extension thereof, distal palmar crease 2/3 of the way to the proximal digital crease, okay? 2/3 of the way, that's A1 pulley, okay? And you should not release the A1 beyond that, then you're getting into A2 territory. Okay, so 2/3 of the way to the proximal digital crease, that's your A. Now, there are many incisions. You can go along the distal palmar crease. On the index finger, obviously you'll do separately because the anatomy is such that it's further proximally. Or you could do oblique incisions. Dr. Kleinert used to teach us to do oblique incisions, especially in the diabetics. They heal better, and so you can do small oblique incisions in this area. So that's how we do it.
Yeah, no, I agree. I kind of do that. I think that's perfect advice. And it is difficult sometimes. A1 and A2 do a kind of transition together. And so you have to kind of be careful with that. And one other thing I'd like to make a point is talking about compartment releases. And Dr. Grossman touched on that as well. But knowing and kind of looking at the anatomy and knowing the compartments, I mean, there are basically 11 compartments, you might say, right? We have 4 dorsal, 4 palmar, and on your interossei, and then you have your, your thenar, your hypothenar, and your adductor, which is often a forgotten, I guess, a forgotten or missed compartment, the adductor compartment. So I think paying attention to those and thinking of exactly the fact that you're trying to release, if you're going to do a full release, 11 things. So that's why I think it's really helpful. And I like to use like the B and C that's shown here. I think that's helpful over the 2nd and 4th web spaces, because I think you can get to what you need to get to there very easily. I don't use A as much to release. I don't know if you do, Amit, if you like that incision. I don't use that web space incision. I find that if you put an incision in the web space, sometimes you regret that later with some scarring and tethering. So I tend to do that release a little bit more volarly.
Yes, you can do that. Don't go across the web space. That's the key, as you mentioned before, okay? And if you go dorsally, you can get to the adductor through this area.
Mm-hmm.
Because the first dorsal interosseous is right over here. As you reflect the first dorsal interosseous, you're just looking at the adductor going across from the 3rd metacarpal to the thumb.
Right. Dr. Grossman, do you have anything that, in regards to that, any comments from your experience that you would like to?
Well, this is actually my patient over here, and so I didn't make this incision for A. I made these 2 dorsal incisions, and I sneaked over in between and then over this way, and then from here I kind of went a little bit volarly. So I was able to get A through a few different incisions. The carpal tunnel release, I actually went a little bit more proximally, crossing the wrist crease, obviously going ulnarly versus radially because to avoid the palmar cutaneous nerve. But I just found that in such a swollen hand, when you're dealing with altered landmarks, I found that going a little more proximally to do the carpal tunnel release was helpful for me in this situation.
Absolutely. Go proximally if you need to. For anything, just go. Doesn't matter. Incisions will heal from side to side, not from end to end. So go proximally, make your incision longer. Doesn't matter. Be safe. Okay. And then you do this as you've done here. Just go a little bit ulnarwards to avoid the palmar cutaneous nerve.
Excellent advice. And on that, we might come back, Lauren, to your.
The other one?
Yep. Go ahead and go back to your.
This one, right?
No, I'm to the end. Go ahead and go back to your after your towards the end. Yeah, I think we've had good discussion. We're about our time. We've come to the end, and I think we've answered all of our participants' questions. I'd like to thank Dr. Grossman. She worked very hard. This is great. You did a great job on this, and thank our participants for hanging in there with us tonight. And hopefully it's been very helpful and a nice review and reminder of some of the pertinent parts of surface anatomy. So Lauren, if you want to take it from here.
Yeah, so here's a calendar of the upcoming events. Next week, we'll deal with hand infections, and every week on Thursday, we'll be doing for 10 weeks total different lectures. So here you can see a calendar, and it was also sent out. And then you can access recording through YouTube. A link will be sent to through Zoom 24 hours after this is over to everybody who's registered so that you could see this through YouTube. Thanks, guys.